Hello, everyone. Welcome for another VMR. Today, I have the pleasure to discuss with Rabih. I'm super excited to have you all here. And yeah, we have a case presenter, Mark, and I think he is his first. No, it's not his first case. He presented one once. Oh my God, he presented his third case. Oh my God. Yeah, we are excited to hear about your case. Rabih, how are you? How was your swimming?
Did you hear that? She said it's her pleasure to discuss with me, but you should have seen what she said behind the scenes. Words that cannot be repeated. I'm very excited. I'm very excited to hang out with you all. It's been a very busy week for me. Clinically, a lot of active patients, a lot of sick people, but always love the opportunity to hang out here and like I said to Deborah, I needed a little bit of a mental break, so I went for a swim. And I needed that mental break because I know that when Mark has a case to present, I think he will not. I think all the neurons that we have available with Deborah will probably be in use. But Mark, how are you?
I'm good. I'm good. Thanks. I just started a rotation at the VA today, which I'm really excited about. Have a great team. Actually, the first patient I got signed out on, their chief complaint, hiccups for 1 year. And I thought immediately of you guys.
Oh my gosh, yes. I think one of the best RLR episodes I've ever been part of was a hiccup case, and I'm excited to see what the conclusion is for you, Mark. That sounds really enticing, chief concern. Awesome. Well, why don't we jump right in? What do you have in store for us today?
Yeah. So we have a patient. We have a 55-year-old woman that's coming in with 10 years of dyspnea and non-productive cough. I'll stop there.
10 years? Okay. I stop it with the 10 years because that maybe my thoughts they are not working. Okay, so we know there's something that is not acute. I think it's something chronic, and I am asking myself why she's presenting now, why this patient had this for such a long time and didn't come to a doctor or to see anyone, look for some help. I would ask more about like this cough. How is it? Is if it has blood, if it's during the night, if it's I don't know if it is, and when she eats something, and if she has when she eats something specific or not. And I'm thinking, yeah, and this dyspnea, like we always think about, like could be something the lungs, could be something the heart, but as has been happening for such a long time, make me, I don't know, what don't make me think about like I don't know acute coronary syndrome or something like that. Make me thinking about something more chronic, like I don't know a COPD, or maybe we have to see the history of the patient if the patient had smoke. Where the patient lives, maybe is the condition where the patient is it, if had some recently travel. But I think that what I'm more specific, it's I would ask why it took so long for the patient to look for some help, and what changed, if something had changed between these 9 years that the patient is in the emergency room now. What do you think, Rabih?
Yeah, no, if we're listening to you, you're clearly saying that there's so many questions, right? What is the nature of her cough? What is the nature of shortness of breath? Why so long? So many questions. And there's no doubt that there's a lot of uncertainty about what this represents. And the challenge for us is to try to get as much to make as much pasta with the flour that we have right now. So I agree with you that there's a lot of gap, but I'm curious what your reflex is to how you think about dyspnea in general.
I always first think about dyspnea, the heart, the lung, and then normally we go for the A's like anemia, anxiety, or anxious. And the heart, I think about if could be a heart failure, acute coronary syndrome, aortic dissection, and I think about the lung if could be an asthma, COPD, if could be a pulmonary hypertension, infection, pneumonia. That's where I will go.
Amazing. So now the question is, how does the cough help you? And so how do you think of dyspnea plus cough?
Make me think more about the lung. That could be something happening. And the first thing that comes to my mind is COPD. And yeah.
Excellent. Excellent. And then now, how do you think of chronic dyspnea plus cough?
Make me think about COPD.
Yeah, right. Amazing. So I think what's really interesting is to show you how you can start to make generalizations. So dyspnea, heart, lung, other. Cough prioritizes lung, but you can have left atrial enlargement from a heart issue that compresses on the bronchus, and that causes a cough. You can have pulmonary edema. So a cough, we have to be careful with language, right? Cough prioritizes lung, but does not eliminate heart. Then chronic. And I think the most likely causes of chronic shortness of breath to last for this long are unlikely to be cardiovascular. And I think the simple rule is the heart is too deep for the problem to be able to last this long. And if you divide the lungs up anatomically into airway, alveoli, pleura, you have to ask yourself, where can I have so much reserve for 9 years? And I think it's much more likely to have reserve in the airways and in the diaphragm, maybe, than it is to have airway in the alveola or pleura. Which is why I think your reflex to say COPD, the most common cause of airway disease in an older adult, is a very wise one. But the question really is, how can you have how can you have protracted symptoms is better analyzed by how can you have a disease process that has been affecting her for 9 years that hasn't caused her to come to the hospital before. And I think airway and diaphragm are probably the most likely scenario in this case. But we have a lot more information, but it goes to show you how even though we have 90% of the information left, how even with a small amount, you can start to have hypotheses to start to work with. And these hypotheses are in pencil, not in pen. You should be able to erase them and change them, but it's not like there's nothing. I think airway and diaphragm are important thoughts. All right, Mark, tell us more.
Such a rich discussion with such little data. Let me fill in some of these gaps for you guys. So like I said, 9 years before presentation, she developed this dyspnea on exertion and a non-productive cough that she said was a little worse when she lied flat, mainly the cough, not the dyspnea. So she was actually diagnosed with asthma and bronchitis by her primary care doctor. There was no PFTs available, however, and she was started on treatment for presumed asthma. And then over the years, she was on this treatment for asthma, but it really just didn't work, and her symptoms progressed. And then 7 years prior to admission, she actually developed pain, swelling, and stiffness in her bilateral hands, and then pain in her bilateral knees. In addition to some mild bilateral hearing loss. And then 2 years prior, she developed really acute worsening of this dyspnea and cough over a week, prompting presentation to a neighboring hospital. That's the end of this outline.
Hey, sorry, Mark. I apologize. I'm actually on service and got an urgent text from my team. Do you mind just saying one more time? I got the asthma part, and then you mentioned some extra pulmonary symptoms. You want to say them one more time? Sorry.
Yeah. So 7 years prior to admission, she developed pain, swelling, and stiffness in her bilateral hands, and then just pain with no stiffness or swelling in her bilateral knees. And then bilateral hearing loss, very mild, but it's just something on review of systems that she's noted. And then 1 week prior to presentation, her symptoms, her dyspnea and cough worsened, prompting her presentation to a neighboring hospital.
Thank you so much. Yeah, Deborah, what do you think?
I'm trying to process all this information. So now we seem like we have a patient that is affected the knees, the hands, and hearing loss. I don't know how, like the hearing loss, it's what caught me. I was thinking about that, but maybe like getting all this together, maybe something autoimmune could be like, we could investigate more that. And I'm wondering if this, like this diagnosis of asthma, if the patient really had asthma, like if could not be something else, like an interstitial lung disease or something that can manifest in autoimmune disease. That's where my thoughts now.
Yeah, no, I completely agree with you. If you had to explain to your medical student what one thing that made you think autoimmune, why? What is it, what you heard that made you think, autoimmune?
When I hear the knees,
Yeah.
was when I start thinking about
autoimmune. I think that's a very good rule of thumb. In general, whenever you have arthritis, you should divide it into mono, oligo, or polyarticular arthritis. And long-standing polyarticular arthritis is almost always autoimmune in nature. Of course, she could have just really bad osteoarthritis, but I think that instinct is very, very robust. And so when you're thinking autoimmune, Deborah, how do you connect that to the lung?
Like I was thinking, like the first thing that crossed in my mind was rheumatoid arthritis. Even though the patient is 64 years old, like she could present. It's more common woman, I think between 40, I guess the age, but like it still can present in her. That was my first thought, and nothing like lupus, I think, can cause everything, like can always be a differential diagnosis.
Yeah, I completely agree with you. How are you? I think that analysis is spot on. How do you think about the hearing loss? What do you do with that?
Being honest, I don't know. I'm trying to think. I will page my dad as he's
That's so funny.
No,
yeah,
nothing. I would like ask her how long time is being this hearing loss. Let me think about it. How hearing lost. Like I would
what's your
think
guess? What do you think the most common causes? Just guess.
I think I would say infection, but I don't know.
Yeah, the good news is the most common cause of sensory neural hearing loss is idiopathic and unknown. We don't really know. A lot of people wear hearing implants because of age. Unfortunately, also how much noise, so cumulative noise, if you go to a lot of concerts in your life, or I work in the Veterans Hospital, and many of my patients have had loud sounds as part of their military exposure. So most of the time, I think the reason you're not thinking about hearing loss so much is because most of the time it is just true, and unrelated. So if you call your dad, I think he'll be like, Deborah, why are you thinking about hearing loss? It's probably not related. But I think if you do some questions and you see she's young, she's only 64, and if she hasn't had a lot of noise exposure or exposure to medications, then you might think, oh, okay, this is unusual. But my advice to you, Deborah, is in most cases, hearing loss is probably going to be an unrelated finding in most people as a result of age. But if we learn that she has not had any noise exposure or that she has family history of this, we might reassess. Awesome. Yeah, I'm very, very intrigued. I think that in real life, we wouldn't know what to do with this information because the baseline rate of osteoarthritis causing hand and knee aches and the baseline rate of hearing loss means that you don't know what the clinical significance of these findings are. But I am very, very intrigued to see what her exam looks like in terms of her joints, and very curious to see if she has any evidence of crackles or wheezes on her lung exam, which I think will help us a lot. But the medical history may give us some clues that I don't anticipate. I'm really, really curious to hear more.
Okay, so now I'm going to give you guys the neighboring hospital course. So like I said, she presented with that acute worsening of her dyspnea and non-productive cough. And when she got to the emergency room, she was actually hypoxic to the 70s. And she was placed on a nasal cannula, and her O2 sats really didn't budge with that. And then she was placed on non-invasive ventilation. Her O2 sats again didn't budge. So then unfortunately she was intubated. And during her tracheal intubation, she was actually found to have 60 to 70% subglottic stenosis. And given this subglottic stenosis, she underwent dilation, and then she was actually rapidly extubated. She had a CT of the chest and a CT of the neck, which showed the severe subglottic stenosis, tree and bud nodularity, and then dependent bilateral lungs, and associated bronchial wall thickening and mucus plugging. So she was placed on steroids, and her symptoms improved. Then unfortunately, 8 days later, she developed, again, acute worsening of this dyspnea, this cough, hypoxemia, and was intubated again. And during tracheal intubation, it showed continued tracheal stenosis and posterior tracheal malacia with about 50% obstruction this time. And then she underwent a tracheostomy and was transferred to my institution for consideration of advanced bronchoscopic therapies. That's the end of this aliquot.
What do you think, Deborah?
I think at this point, I always try to think is this patient sick or not sick, and this patient is really sick.
Yeah.
Make me think what is causing this subglottic stenosis, what if the patient already had that, if it was something congenital, if it was something because of the intubation that can cause that too.
Excellent. Excellent.
Yeah, I think we need to know how's the vitals now.
Yeah.
Do a CT to see to discover what is happening.
Yeah, before you move on, I want to congratulate you because I think knowing how strong you are clinically, you're already looking forward. But remember what you first said about what you think she might have. You said COPD, right? And she doesn't have COPD, but she has an airway disorder, right? You see how that thinking that you had was correct. It was, you gave an example of the most common cause of an airway issue. She has an airway issue, subglottic stenosis. So I encourage you to go back and be like, okay, good. My thinking was right. I thought chronic, I thought dyspnea, cough made me think lung, chronic made me think airway, and here we are, right? And it's important because otherwise you don't get these thinking reinforced, and you'll only believe something as a finding if you had pre-test probability for it. And so I believe that she has subglottic stenosis because it makes sense to cause such long-standing symptoms. And you're absolutely right. The most common cause of subglottic stenosis is related to trauma from endotracheal intubation. But now we should slow down. We have the pivot. We have the pivot point, subglottic stenosis. And so you should try now to take some time and think creatively of what else you might think causes subglottic stenosis. And then I will share with you more, but try to think from maybe guessing or thinking about these kinds of things.
I was trying for something congenital, but I being honest,
yeah,
the first thing that crossed my mind is about the intubation, and
excellent. Excellent.
That's where my mind is now.
Yeah, 100%. Only sometimes you can find things that you've learned in the distant past only if you've asked your mind the right question. So earlier you said, I'm worried about autoimmune disease. So now that you're layering autoimmune disease and subglottic stenosis, can you think of anything, or have you learned any autoimmune diseases that can cause subglottic stenosis?
I don't remember.
It's
But
very, very rare. But
you can.
maybe you can try just to do what you would do in real life. I will talk about some other things. Maybe you can do what you do in real life. Just do a quick Google autoimmune disease and subglottic stenosis and just tell us what you find. Okay? But while Deborah is focusing on that, I think the thing to really emphasize is that the subglottic stenosis is not an immediate explanation for her hypoxemia. Hypoxemia implies a disorder at the alveolar vascular interface, and airway issues do not readily explain hypoxemia. But what could happen in patients with airways disorders? They can get collapse or atelectasis, and that can certainly cause hypoxemia. And they can manage their secretions in a suboptimal manner, and that can cause aspiration. And you can also get atelectasis from mucus plugging. So it would be really, really interesting to know what happened at that incident event. But you can see the subsequent CT is showing evidence of poor airway clearance with the bronchial wall thickening and the mucus plugging. And the mucus plugging alone may account for hypoxemia. But just want to emphasize the point that when you're diagnosing an airway issue, the most common manifestation is stridor and hypercarbia, hence COPD, and hypoxemia needs another explanation. And that other explanation in COPD is that the patient has emphysema, destruction of the alveoli, and other common explanations for concomitant alveolar disease in a patient with airway issue is atelectasis, mucus plugging, and aspiration. So the hypoxemia isn't directly related to the subglottic stenosis. So Deborah, what have you found so far?
Okay, I found that lupus can cause granulomatosis with polyangiitis and sarcoidosis.
Excellent. Absolutely superb. So there are many causes of subglottic stenosis. The vast majority of them are non-inflammatory diseases related to trauma from prior intubation. There are some congenital issues. It's also important to recognize that something that Deborah, you actually discussed or presented, which is, do you remember iron pill aspiration syndrome? So that, yeah. That can also, it usually causes lower stenosis in the bronchus, not the subglottic, but it can also do it. Within the inflammatory category, infections are less common, but the most notorious infection is tuberculosis. Rarely, HSV and Aspergillus can do it in the right clinical context. But the overlap of autoimmune disease and tracheal or subglottic stenosis is extensive. There's many things that can do it. GPA, rheumatoid arthritis, inflammatory bowel disease, and relapsing polychondritis are notorious in terms of their ability to do it. So I think because of what you said earlier, Deborah, we should put the highlight around autoimmune disease, the knee pain. So the autoimmune disease is GPA, sarcoidosis, IBD, RA, and relapsing polychondritis. Can you think of any of those that can link with the hearing loss that the patient has?
I think GPA.
Excellent. GPA can cause a lot upper airway symptoms and cause hearing loss. The
sarcoidosis too, I guess.
Yes, sarcoidosis can infiltrate the nerve and cause hearing loss for sure. And relapsing polychondritis. Relapsing polychondritis is centered around the ears and the eyes. Of those things, I think we'll need to pursue all those hypotheses, but the only way we can, GPA, we can do some testing, sarcoid, we can do some testing. The only way that you can really look into the idea of relapsing polychondritis is to talk to the patient and ask her if she's ever had prior episodes of swelling of her ears, her eyes, or her nose. So moving forward, we have to analyze the possibility of those conditions. But in order to suspect relapsing polychondritis, you have to move backwards and ask about history of prior events. And I forgot to mention, at the end of the day, if you find nothing, there is an entity called idiopathic subglottic stenosis that, guess what, happens most commonly in middle-aged women. There was a very nice New York Times diagnosis column by Lisa Sanders that describes this case. So any questions about any of that, Deborah?
No, thank you.
Okay, I'd love for you to practice. So what stuck with you for subglottic stenosis? What did you learn from this conversation?
What I learned the association with autoimmune disease, that we talk about all those causes, I think was the pearl for me so far.
Awesome. Okay. All right. Let's get some more information.
I'm absolutely loving this discussion. And just to fill in some of the questions you guys had. So no prior history of swollen nose, ears, or anything like that. So next I will present the background data and then also the exam when I met the patient. So for the background data, the patient also had a history of hypertension, hyperlipidemia, and anxiety. Some medications she was on amlodipine, fluoxetine, buspirone, bupropion, and atorvastatin. Her allergies were to codeine. Her family history was saying that her mom had rheumatoid arthritis and her paternal grandfather had COPD. And for her social history, she never smoked, never drank, no recreational drug use. She lived in Maryland with her husband, and she was a history teacher, and she was most proud of her career as a softball coach. And then moving to the exam, her vital signs were all stable. She was afebrile. She was comfortable appearing when I saw her and no distress. On HENT exam, I didn't notice any tenderness or deformity in her nose or her ears. I didn't appreciate any lymphadenopathy. Her cardiovascular exam was normal. Her pulmonary exam, she was in no respiratory stress. Her lungs were actually clear, no wheezing, and she had a trach in place for her speaking valve. Her abdominal exam was normal. Her exam was normal. And then for her MSK exam, on her hands, her right, second, and third MCP were tender and swollen, and her left, second, and fourth MCP were tender and swollen. But her PIPs were normal. She did have nodules, it's kind of scattered on her DIPs bilaterally, but they weren't tender or swollen or red. And then I did mention the bilateral knee pain that she reported in her history, but her knees, there's no tenderness on palpation. They weren't swollen. They weren't red. And then for her skin, no erythema, no rashes, no nodules. And that's the end of this outline.
I think what catch my eye here is that the family history that her mom has rheumatoid arthritis, and the patient, like, seems really stable with, like, I didn't saw anything on the lungs, but when I heard like she had some nodules and bilateral, make me think about rheumatoid arthritis too, if this could be the cause of her presentation. I think those were my first thoughts.
Yeah, no, I completely agree, Deborah. I think that whenever you see nodules and arthritis, there are two common things that can do that: RA and gout. And while, believe it or not, gout can actually infiltrate the back of the throat, there have been case reports of gout causing tophi in the lung, in the airway. I think RA is probably a better explanation. The interesting thing about RA is most of the time the arthritis is symmetric, so all the joints are equally involved. And so in her, the fact that she has disproportionate arthritis in some aspects is unusual. I also am not entirely sure about this, but I think the nodules don't usually occur on the DIP joints. They usually occur on the elbows or in other areas. So I think it's be really, really interesting. I definitely think we need an extensive autoimmune evaluation, and we might land on RA if the testing is positive, or we might have to invoke less common causes of arthritis plus nodules to give us a clue. But at least the lack of prior cartilage symptoms makes relapsing polychondritis less likely. I think in this patient, getting a UA, which you might not otherwise get, is so crucial for the hypothesis that Deborah said earlier, which is maybe GPA. So very, very intrigued. Definitely even more in the autoimmune hypothesis now that we see synovitis and now that we see nodules too. All right, Mark, tell us more.
All right, so now I'll move on to some labs. So for her BNP, her sodium was 140, her potassium was 3.8, chloride 105, bicarb 25, BUN of 13, and creatinine of 0.7. For her CBC, her white count was 6.8, her hemoglobin was 11.9, her platelets were 344. For her LFTs, she had an ALT which was 16, AST which was 18, an alk phos which was 87, a total bili which was 0.5, a total protein which was 6.2, and an albumin that was 3.9. For her coags, she had an INR which was 1, a PTT which was normal at 29. She had a UA which was completely bland, no hematuria, no proteinuria, no pyuria. She had an ESR which was 12, and a non-cardiac CRP which is normal at 0.5. And she had an ANA that was negative, an RF that was negative, a CCP that was negative, an ANCA that was negative, and an SSA and an SSB which were negative. And the next aliquot will reveal the diagnosis.
Mark, can I ask one quick question? Do you ever get any x-rays of the hands or the knees or anything like that?
Yeah, so the x-rays just showed some swelling of those areas that had pain and swelling.
Gotcha. But like
no destruction.
Yeah, okay.
Yeah, no destruction.
Nothing crazy. I don't know how to read those things, honestly, but there was no prominent like osteoarticular disease on the x-rays. Okay, cool. All right, Deborah, what do you think?
Yeah, I think a lot of maybe our possibilities were take off, but that's good, you know, we can find the diagnosis, the right one. I'm trying to think if maybe like could be like a autoimmune disease with negative serology, or if it could be like a no way. Yeah, I don't know. What are you thinking? You are muted.
Sorry. I think you said it exactly right. Is it an autoimmune disease with negative serology, or is it actually that these things are unrelated? And I think that's the correct question. So if you did some reading, you'd see that the RF is only 70% sensitive for rheumatoid arthritis, and the CCP is a little bit more sensitive, but not quite. But the interesting thing is, if you're diagnosing rheumatoid arthritis with extra articular manifestations, namely this, the sensitivity of RS and CCP is much higher. So it's more unusual to diagnose seronegative RA in a patient with extra articular manifestations. So I think that significantly reduces the probability of RA. But Deborah, this is one thing that I learned in real life, is x-rays are also really helpful. If you're diagnosing such bad RA that there are nodules and subglottic stenosis, you expect some erosion on the x-ray. And the fact that the x-rays are normal makes it much less likely. ANA is a great test for lupus. Deborah, do you have a rough idea of how many patients with lupus have negative ANA?
I think it's really low, but
yeah,
I don't have a number.
Super low, like 3-4%, very, very low. So lupus is unlikely. GPA, ANCA negative GPA is possible. It's more likely in limited disease, but the fact that there's no nodules in the lung, the fact that their UA is negative makes that less likely. So if I were taking care of this patient, I would definitely wait and be open to her declaring herself. But I think that my sense is these three things are unrelated. She has regular old sensory neurohearing loss. She has osteoarthritis with nodules. especially with the fact that the nodules are on the DIP is supportive of OA. And then she has probably idiopathic subglottic stenosis, a disease of middle-aged women. So anytime you're diagnosing anything idiopathic, you have to be open to the disease evolving and that you being wrong. But that would probably be my working hypothesis now. Any thoughts about that, Deborah? Anything you want to clarify before we learn from Mark? All right. Cool.
Yeah.
Yeah. Tell us more, Mark. Oh, you're muted.
Muted.
Oh, sorry. Is there any way that someone can make me co-host and I could share an image?
Yeah, give me one
Awesome.
sec.
Yeah.
Sorry, I should have done that earlier.
No, no worries.
Trying to guess what your image is going to be. This is so cute.
Okay. Are you guys able to see my screen?
Yes.
Okay. So the patient underwent a repeat bronchoscopy that showed this finding. I don't know if anyone could venture a guess of what's going on. I had no idea when I saw this bronchoscopy image, but this finding sealed the diagnosis for the interventional pulmonologist. They said it was pathognomonic, and I've never heard of this before.
I have absolutely no idea. Deborah, do you know?
No.
I just don't know what I honestly have no idea where to even orient myself because I've never looked at these before. So excited to learn from you, unless somebody in the chat, anybody in the chat has any idea what they're looking at? Stenosis, external.
Jess, that look like a bronchos. Thank you, Jess.
All right. So really good thoughts in the chat. Adhesions, bronchus, stenosis. Mark, teach us, please.
Yeah. So there's actually complete loss of the anterior cartilage in the trachea right now. We should see nice anterior tracheal rings, but there's absolutely no tracheal rings here, which is called esophagalization. That's a really hard name to pronounce, of the trachea, which is pathognomonic for relapsing polychondritis. So I feel like it wasn't fair to be able to guess the next test because this test has been done. This test has been done before, so I think it was a little unfair in that sense. But our interventional pulmonologist saw that and said this is almost 100% specific for relapsing polychondritis. So I actually was on rheumatology consults at the time. And the patient was started on a prednisone or a methylpred first and had a lot of improvement in her symptoms. And then followed up as an outpatient with the rheumatology team here and started actually on tocilizumab for relapsing polychondritis because it seems like it's been shown that relapsing polychondritis, especially with synovitis, which the rheumatologists attribute the synovitis as a kind of symptom also of relapsing polychondritis, which can happen in up to like 40 to 50% of patients. Tocilizumab has been shown to have some benefit. So yeah, the patient has relapsing polychondritis.
Fascinating. Deborah, what do you think?
Amazing. Thank you so much, Mark. Amazing case. I learned it a lot. And yeah, it's always good to learn, especially from the lungs. What do you think, Rabih?
Oh, I'm just really intrigued because I've never seen relapsing polychondritis in real life, but reading about it makes you believe that vast majority, if not everybody, has some history in their ears, nose, or eyes. So I'm curious, Mark, what was that experience like when you were when you saw something pathognomonic here, but there wasn't anything to link to outside the trachea? How did you all discuss that, navigate that? What was that like?
Yeah, I mean, our wonderful rheumatology attending said that, it is rare to have, isolated subglottic stenosis and, synovitis for relapsing polychondritis, which is an extremely rare disease at baseline. But after reading up to date, it seems like, at presentation, about like 30 to 40% of patients will have ear involvement. Over time, almost 90% of patients will have ear involvement. So, depending at what time the patient presents, you could, who knows, maybe 5 years from now, she'll develop ear involvement, nose involvement, eye involvement. But I think for me, it was like, this is an extremely hard diagnosis to get to, especially because there's no, serological test, right? It's going to be a bronchoscopic diagnosis. So I'm just thinking, I thought after I like reflect on this case for a while, I'm like, how could have we gotten to this diagnosis quicker? Because it's not just about getting the diagnosis right? It's about getting the diagnosis efficiently to prevent morbidity. This patient had a long outside hospital stay, got a tracheostomy, right? So she had a significant amount of morbidity from this diagnosis. And I think this highlight for me is that I always forget about the upper airway when I think about a patient that presents with dyspnea. When I'm going into the lungs, I go right for the large airways, the parenchyma, the alveoli, the pleura. I always forget about the upper airway. So I think it makes me think, if a patient is labeled as having like a large airway disease, and it doesn't have PFTs that show obstruction, could this be a large airway problem or a upper airway problem? So I think that really ingrained that into my mind, is just always consider the upper airway when someone has chronic dyspnea.
I love it. That's such a great actionable takeaway. Thank you. And Deborah, what was it like discussing? What did it feel like?
It was great. Thank you. You make me feel really comfortable. And yeah, thank you for the teaching points, Mark. I will definitely do a reflection with this case.
Yeah, I think that all of us are very interested in trying to be as good as possibly can be. And Deborah, if you just go back and watch, you said you analyzed all these symptoms. You said this is an airway problem. Then you heard about the knee pain. You said autoimmune. And that's all you really need before you start to just be able to Google the answer. And it goes to show you that all of us have something left to learn. And for me, what I have left to learn is to realize that there are some pathognomonic findings on visualization of the trachea in these patients, which is really, really cool. So I can't wait to dive deep into that. Yeah, I think one big takeaway that I would share with you all is which was what we started with, which is somebody is really having dyspnea for so long and hasn't progressed to become so serious. I think the only way that's possible is if you're short of breath from the most superficial process possible, the airways. And Mark reinforced that point because this person has literally the most closest part of the lung to the world is the site of disease. And I think it was really cool to see that thinking translate into the diagnosis today. So thank you, Mark. Yeah, really, really helped the case. I can see why you were buzzing to present it. It's very, very educational. And I hope you think about writing it up. I think it would be really cool to have it out there on the literature.
Yeah, and it's so amazing how I've reflected on this case for so long, and I just learned so much from both of you. So thank you so much.
Absolutely. Alrighty, Mariana, take us home, please.
What an amazing case, Mark. Congratulations for this presentation. Thank you, Rabih and Deborah for the discussion. And okay, here we go. So our patient started with dyspnea. And when you think about dyspnea, we can think about heart, such as heart failure, or lung, thinking about asthma or COPD, and also blood, thinking in anemia. But our patient also had cough. And when we have a patient with dyspnea and cough, we need to think about mainly lungs, but it does not eliminate heart. And our patient also has a chronicity, so it's unlikely to be cardiovascular, but it still can be. But we decided that we were going to study the lungs. So thinking about lung, it could be an airway or alveoli or a pleural disease. And thinking about a reserve for 9 years, we probably had an airway or diaphragm disease. And after HPI, we had more symptoms, associated symptoms. So we started to think about an autoimmune cause that could be interstitial lung disease or lupus or RA. And when you have arthritis, it can be mono or oligo or polyarthritis. And when we have polyarthritis, we have to think about autoimmune disease. Our patient also had hearing loss, and most causes of hearing loss are idiopathic, but and it could be easily related to because of aging. So we could easily, it could be unrelated to the chief complaint. And our patient also had an airway disorder after we found out that the patient had subglottic stenosis. That is the most common causes related to trauma due to intubation. So at this point, we had no idea what we were talking about, but after we found out that is related to an autoimmune disease. A really important thing that I learned today is that subglottic stenosis is not an immediate explanation for hypoxemia. What happens is that we have an airway disorder, and after we have or atelectasis or mucus plugging or aspiration, and after we have a hypoxemia. And when you think about autoimmune disease, but plus subglottic stenosis plus hearing loss, we can think about GPR or relapsing polychondritis. And when we think about only autoimmune disease plus subglottic stenosis, we can have trauma or congenital disease or infections such as TB or Aspergillus, or inflammatory or idiopathic. And after all, we had a bronchoscopy with esophagalization of the trachea, what is a pathognomonic sign of relapsing polychondritis, which is a rare autoimmune disease. And that's it.
Amazing, Mariana. That was so good. So focused on the highlights, and I love that you bolded the subglottic stenosis and hypoxemia part. I forgot to reemphasize that. That's really, really key. So thank you. Thanks, Mark, for an amazing case, and Deborah for getting basically the category of the diagnosis in aliquot 2. I'll have a lot of reading to do. So thank you, Mark, for all the homework. My call team is going to be very mad at me because I think I won't answer my phone for the next hour reading about this condition. Thanks, y'all. See you tomorrow.